Our next speaker is going to be Dr. Stephen Humphries, an imaging scientist from National Jewish Health. He's going to talk on new HRCT quantitative methods to enhance trial design and clinical assessment.
Thank you for the introduction, Dr. Lynch, and thanks very much to the PFF for the opportunity to present today. So what I'll go over is our current work and results focusing on the development of computer techniques to analyze CT scans to quantify extent of disease present. Here are my disclosures. So as is well known in this group, idiopathic pulmonary fibrosis has an inconsistent and unpredictable natural history, and this presents problems both in clinical care and design of clinical trials and drug development. So the rate and severity of disease progression is known to be highly variable. And there is a recognized need for new tools or new markers to gauge the severity of disease at a given point and predict risk, also to evaluate in a precise and objective way change over time. And then increasingly, it's acknowledged that detection of early disease is an important issue. CT, or computed tomography, is the preferred imaging modality of the lung. So CT provides a non-invasive picture of anatomy at a given time and certainly plays an essential role in evaluating IPF and other lung disease. In the context of IPF, CT findings are important because they may be sufficient to diagnose UIP without a surgical biopsy. It's also known from previous work in visual assessment that the presence and extent of key features on CT are associated with the severity of disease and risk of mortality. And CT pattern is, or has been used as entry criteria for clinical trials. So again, CT is an important tool and a good target for development of new methods to improve precision and objectivity in analysis. The challenge with visual assessment of CT is that visual assessment is subjective and somewhat imprecise, which makes it difficult for longitudinal assessment. Radiologists are presented with a lot of information in a volumetric CT, and radiologists are excellent at pattern recognition and integrating a lot of information, but detection of specific features and some quantification is just a challenging task for sort of the human visual system. And in addition, misclassification of the pattern of CT, pattern on CT, can hamper diagnosis. So while CT captures a lot of useful information and is an essential tool in practice, there are these limitations of the status quo. And this motivates research and interest in computer techniques to quantify the appearance of patterns on CT. Sam Ash gave a very nice presentation earlier this afternoon and provided some background on objective computer methods in detection of ILA. There is a very nice review earlier this year in the Blue Journal that reflects the interest that many groups have in leveraging computer techniques for detection and quantification of interstitial lung disease. So it's really a rich area of interest. Various engineering groups have applied different techniques, and I don't have the time to go into sort of the difference between various things that have been published, but I think an important thing to recognize is just that CT as an imaging modality captures a rich presentation of anatomy at a given point in time from which meaningful quantitative information can be extracted. But we're at a point where we need elaborate computer tools to fully capitalize on the information that's present in the CT scan. So I'll focus on a method that we've developed at National Jewish, focusing on image texture. So this is a bit of a busy slide, but the intent here is to make the point that The patterns that we see in images are formed not only by the individual pixel intensities, but also their spatial relationship. And we call this quality in images texture. So these three sort of collages are made up of 2 by 2 centimeter patches randomly extracted from a variety of scans, showing on the left side what normal lung parenchyma tends to look like. The center panel is a similar montage of reticular abnormality that was identified by a radiologist. And on the right are local regions of honeycombing. So I think you can see that there's a noticeable difference between these patterns, and when you sort of step back and look at it in this presentation at a distance, you get the sense that there's distinct patterns associated with each of these label names, but it's difficult to, say, design or identify a rule that might help you systematically distinguish these. It's sort of I know it when I see it. And this kind of problem, when approached from a computer vision standpoint, would be termed a texture classification problem. And the issue of learning by example is really the strengths of machine learning techniques that are being leveraged currently, particularly the field of deep learning. A data analysis model used in image analysis and deep learning are convolutional neural networks. And these are computer programs that, when trained in a supervised fashion, meaning input data is shown to the model along with the desired label, the computational workings of that type of algorithm adapt to optimize both feature extraction and classification rules simultaneously. So in other words, the computer program is able to, based on examples that are provided during training, learn the essential features that distinguish one pattern from another, as well as the classification rules. So this is a very powerful technique that many groups are leveraging, and we've applied this to develop a method for detection and quantification of lung fibrosis on CT. Since three-letter acronyms are so tempting, we ended up with the name data-driven texture analysis to refer to our current algorithm, or DTA. And this method was trained using hundreds of regions of CT images that were labeled by radiologists, labeled by one and then verified by another. So we were able to capture many examples of the patterns of interest and train an algorithm to detect these. The final result of the DT method in an individual case is a percentage score that shows the percentage of total lung volume that was classified as lung fibrosis. Here's a schematic to give a general overview of the process. So starting from the left, the green 3D models there are lung segmentation. So in an initial deep learning process, the CT scans are analyzed to identify the boundaries of the lung, and this gives us a measurement of volume and sort of the denominator to the final calculation. Following this step, you can imagine a sliding window classifier where, say, the yellow block represents an individual classification that the algorithm performs. But that yellow window is sort of slid across the entire image or the entire lung field, performing classifications at each step. And the classification is either, does this patch appear to be lung fibrosis or not? So it's termed a binary classifier. And the coronal images on the right just give an idea of the final output. So we look at the total lung volume, count up how many local areas were classified as fibrosis, and produce a numerical score. And it's that final score that we've focused on. So at this point, we've had the opportunity to apply this method in a few thousand cases in different contexts. So my next several slides will just kind of give an overview of validation testing that we've been able to perform in different cohorts. Some of these cohorts were from clinical trials, some were research studies, as well as registries. So in the first round of experimentation we did focused on the IPF-NET cohort, which was a clinical trial from some time ago. And what we found was that the extent of fibrosis, quantified it in this way, was correlated with lung function as well as visual scores, so that the algorithm agreed with radiologists and gave a score that was correlated with lung function, but the correlation between the computer score and lung function was statistically stronger than the correlation between the visual score produced by radiologists and lung function. So that visual score was a semi-quantitative estimate of the extent of lung fibrosis, so the radiologists gave a 0 to 10 score, so for deciles of lung involvement in that case. In a separate clinical trial population, we had the opportunity to look at risk associated with the extent of fibrosis on the baseline CT scan. So in a recent letter, these results were published, and in a group of 500 participants in a trial, it was found that for each percentage point increase in the extent of lung fibrosis detected by computer, hazard ratio was 1.02 for risk of disease progression or all-cause hospitalization. So this gives us some evidence or some suggestion that a tool like this, or at least a computational approach to analyzing CT scans, may be useful to stratify the severity of disease in populations for clinical trials. Similarly, we looked at a national registry of patients with IPF and found that the extent of fibrosis detected automatically was associated with transplant-free survival. So this Kaplan-Meier curve, the 3 lines there show different extents of lung fibrosis, so tertiles of lung fibrosis. So with increasing extent of fibrosis on a baseline CT scan, risk of mortality or transplant increases, and those groups were significantly different. When we did a similar analysis using a multivariable Cox model for survival and adjusted for baseline pulmonary function, we found that the extent of lung fibrosis was an independent predictor of survival. So that suggests that the information we're able to quantify from the CT scan is independent from measurement of lung function. Now, looking at change in the amount of lung fibrosis over time, we pooled participants, or pooled data on participants from 2 trials in order to get a group of 140 that had CT scans at baseline and then a second CT at about 15 months. And we found that the amount of change in the lung fibrosis that we measured was significantly associated with the amount of change in lung function based on FVC and DLCO, as well as the change in exercise capacity with 6-minute walk distance, as well as patient-reported quality of life. So in other words, when we've measured a change in the amount of lung fibrosis on sequential scans, that reflected or was correlated with other changes in status. The minimal clinically important difference is an interesting measure. The idea here is to measure the smallest amount of change in a metric that would be meaningful to a patient, say. So this is an important characteristic for population studies because we'd like to know, what level of change we should worry about. This table is a little busy, but the point here is that using what's called an anchor-based approach, we identified our individuals in this cohort who had declined slightly by change in their forced vital capacity. And in that group, the mean change in lung fibrosis extent was about 3%. And using this approach and then a couple others to estimate the MCID value, we concluded that in this group we saw about, if lung fibrosis changed by about 5 percentage points on a sequential scan, this was associated with a meaningful clinical change. We've also had the chance to apply this approach in a separate group working with Dr. Schwartz's group at University of Colorado to detect early fibrosis in patients who had not previously been diagnosed with interstitial lung disease. So in a cohort that was identified to be at risk based on family history, we analyzed CT scans and found that the computer score was concordant with a radiologist's visual diagnosis of the presence of fibrotic ILD. And in addition, we saw that those with a known genetic risk factor, the MUC5B variant, also had a significantly higher lung fibrosis score on quantitative CT. So this gives us some confidence that a computer technique like this is able to detect subtle levels of fibrosis that are related to other known risk factors. Just to illustrate this with images, these are pairs of images that had been classified as having no fibrotic ILD on the left, or probable by visual diagnosis versus definite. So the red areas were identified by the computer, and the scores at the bottom reflect the extent over the total lung volume that's classified as fibrosis. So again, this illustrates that the computer is detecting something that's visible by eye. I should also note that in this analysis, we found a somewhat stronger correlation with the genetic risk factor, comparing the quantitative score and the genetic risk factor, and not so much with the visual scores. So there are a few challenges to be noted, especially in undertaking future projects that would rely on CT, and these are really important to emphasize, I think, in terms of successfully applying these kind of techniques in projects. And the real-world challenges we face are that CT scanners at different sites have different characteristics, manufacturer and model. There may be different components in the radiation, the X-ray tubes, different versions of machines use different softwares, et cetera. And these are well-documented issues in other areas of quantitative CT, say in emphysema. Another important factor is the image geometry, and by that I mean slice thickness and spacing. So we'd like to cover the whole volume of the lungs with as thin sections as possible, with narrow or contiguous spacing, so we're able to get an accurate picture of the total lung volume. Another factor that's important to try to control is the variation in level of inspiration. Typically, we use an inspiratory CT scan to quantify the amount of fibrosis. And of course, level of inspiration can vary from individual to individual. So in applying such a technique moving forward, it's a good idea to have a good plan for coaching, say, CT techs and CT departments on how to advise their patients and prepare their patients to obtain a scan at a fairly consistent level of inspiration. Another factor is that the modern techniques that we use, deep learning and machine learning, really rely on large amounts of curated data. And this takes some time and effort to organize, and I think underscores some of the comments that we've heard in prior presentations, particularly regarding registries and the value of well-characterized cohorts that include not only clinical data, but CT scans. Particularly independent cohorts are very useful and necessary for development and validation of these new computer techniques. Another issue is that the algorithms that we develop in our independent labs or different companies that are developing these things are not totally standard. You know, we're working on new ideas, and again, I think an important point is that computer techniques are increasingly showing promise as a way to extract the rich information that CT captures, but there's different ways of going about it. So to conclude, quantitative CT techniques are emerging as clinically valid objective indices of severity in IPF. We've seen that the amount of fibrosis on a baseline CT is related to physiology and associated with progression, associated with the risk of progression. So this gives us the idea that we can use this as a tool to objectively characterize disease severity at a given point in time, and this might be a useful technique for stratifying or enriching populations in trials. We've also seen that computer techniques are capable of measuring change and are sensitive to change with our estimate of an MCID of about 5%. And we've seen that computer techniques are capable of detecting early fibrosis, and this is a real promising avenue of future research. So with that, I'll thank my team and my collaborators, and thank you for your time.